My name is Nozomi, and today I will be giving a brief overview of hypoxic ischemic encephalopathy and critical care transport. I have been a nurse for nearly 5 years with a background in emergency and trauma medicine. I chose this topic to present in my critical care transport academy because I came across this condition only one time during my career and wanted to have a better understanding of it for myself. My hope is that this overview will serve as a guide for others who are also entering into the critical care transport field. During this presentation, I will be discussing what hypoxic ischemic encephalopathy is and its significance in the world of neonatal health and how it impacts critical care transporters. I will briefly discuss the pathophysiology of HIE, the current interventions and treatments, and I will discuss some of the complications and contraindications related to the transportation of these patients with HIE and some other special considerations. So just to quickly jump in here, we're going to define hypoxic ischemic encephalopathy, or HIE. HIE is an acute neurological injury that can occur as a result of a hypoxic ischemic event during prenatal, intrapartum, or postnatal period. Hypoxic ischemic events are any event where oxygen and blood flow are disrupted to the fetus, causing a sudden brain injury that can have other physical consequences depending on the severity and length of deprivation or injury. Some of the initial signs and symptoms of infants with HIE may be quite subtle. While in utero, providers may find abnormal fetal heart rate tracings. Postpartum, we may see low APGAR scores without improvement over time, respiratory distress, and poor umbilical cord gases. And we'll talk a little bit more about why that is when we go over the pathophysiology of HIE. For the purposes of this presentation, in the context of critical care transportation, I will be focusing on the moderate to severe cases of HIE. More minor cases of HIE are quite common given the mechanism of childbirth. However, moderate to severe injuries occur approximately 1 to 2 births for every 1,000 live births given in developed countries. Even with interventions, 40 to 60% of affected infants with moderate to severe injury die by the age of 2 or live with severe neurological or physical disabilities. When I say disability, this is not an all-inclusive list, but it can include mental retardation, epilepsy, cerebral palsy, blindness, and even deafness. All right, so to keep moving towards interventions and treatments, I am going to try and review some of the pathophysiology of HIE, which makes complications so complex. And I'm going to start by breaking down HIE into its individual parts, and then I'll try and put it back together again. Hypoxia, or the hypoxic portion of the injury, can happen, as I said, early, either in utero or while the mother is in labor. Ischemia refers to decreased blood flow to the fetus before they are born or also during labor and postpartum. Encephalopathy is the swelling of the brain. In HIE, encephalopathy is the result of the hypoxic and ischemic injury. So factors that increase the risk of HIE are medical emergencies related to childbirth. We can see hypoxic and ischemic injury every time the blood supply to the fetus is compromised. This includes placental infarct insufficiency, cord prolapse, uterine rupture, maternal hypotension and anemia, and so on. During these events, the fetus is getting deprived of adequate oxygen-rich blood and starts to show signs of injury. HIE is a super complicated chain of events physiologically, but when it's discussed in the literature, it's typically broken down into 2 phases of what they call energy failure. Phase 1 is the primary energy failure. During this phase, there's decreased cerebral blood flow to the fetus or infant, depending on when in the labor the injury takes place. And again, this could be from any of the risk factors that I discussed previously. So in the instance of cord prolapse, the fetus has decreased blood flow. This decreases the available oxygen and glucose. And this decrease triggers a cascade of events, including decreased ATP availability and production. And then we get a spike in lactate and a decreased glucose supply from the decreased glucose supply. This ultimately leads to the sodium-potassium pumps failing. There's a huge imbalance of electrolytes with this pump failure, and the cells begin to swell and rupture. When these ruptured cells continue to dump their contents and trigger more swelling and inflammation, that's what leads to the encephalopathy or the brain swelling. So this phase 1 starts the moment that there's an ischemic or a hypoxic injury. The second phase, which is referred to as the secondary energy failure, typically occurs 6 to 48 hours after the initial injury. This phase is made up of continued oxidative stress and inflammation and is marked by free radical injury. Infants don't have effective or efficient ways of clearing all the free radicals that are formed during phase 1 injury. So phase 2 is continued damage and inflammation. So just to review, HIE is an acute neurological injury caused by hypoxic ischemic events that cause inflammation, leading to brain swelling or encephalopathy. So now we're going to go over the standard of care for these patients. Therapeutic hypothermia has been found to be the most effective in patients with moderate to severe HIE. The goal of therapeutic hypothermia is to slow the inflammatory response happening during phase 1 of the injury. Therapeutic hypothermia requires constant monitoring and medical interventions, so these patients must be transferred to a neonatal intensive care unit or a NICU. If there's not one available at the site of the delivery, then those patients must be transferred to a tertiary hospital where there's a NICU with therapeutic hypothermia available. So, who needs to know about these interventions? Because HIE is difficult to anticipate even under the best circumstances surrounding a delivery, it requires a lot of diligent monitoring. This means that in order to recognize and diagnose early, it needs interdisciplinary cooperation. Nurses, first responders, and doctors or anyone who's a part of a delivery should be aware of risk factors and signs of HIE so that we can facilitate immediate interventions and get these patients to the right place. The goal of therapeutic hypothermia is to intervene as soon as possible during phase 1. Studies have shown minimal benefit after the 6-hour mark. The most benefit was seen when therapeutic hypothermia was deployed within the first 3 hours or less than 6. So, what is therapeutic hypothermia? The therapeutic range for newborns with HIE is 33 to 34 degrees Celsius, and that's referring to their core temperature, not their peripheral. And as I said before, this should be achieved within 3 to 6 hours of injury for best outcomes. So I'm going to bring this back to the transportation of these patients and some of the special considerations there. Therapeutic hypothermia can be difficult to control even within a hospital environment like a NICU. There are 2 ways of cooling down a body, and we can do active cooling with gel packs and cooling mattresses and cooling blankets, or we can do passive cooling, which would be like unbundling an infant from their blankets or not having them under a heating light. Active cooling has been shown to be more effective compared to passive cooling, but active cooling devices may not be available to all flight or transportation programs. They are typically much more expensive and can be large and heavy and difficult to power in an aircraft. Therapeutic hypothermia also requires constant monitoring to ensure that peripheral temperatures of the infant are not too different from the core temperature. Some of the things to think about with therapeutic hypothermia are the side effects and complications when managing. Side effects of therapeutic hypothermia include bradycardia, hypotension, decreased respiratory drive, subcutaneous fat necrosis, and coagulopathy. These patients require a high level of care and may be difficult to get IV access on. Patients with HIE already have decreased respiratory drive due to the encephalopathy. So when we start them on therapeutic hypothermia, we can decrease that respiratory drive even more so. And so we need to be really judicious with our respiratory management in order to maintain adequate oxygenation without further causing physiological damage. Now, I'm going to go over some of the contraindications for therapeutic hypothermia and when the interventions would need to be stopped. Here are some of the conditions that would exclude a patient with HIE from receiving therapeutic hypothermia. Major congenital or genetic abnormalities, severe intrauterine growth restrictions, or evidence of severe head trauma or intracranial bleeding. And on the right side, we have a list of symptoms that would make us stop therapeutic hypothermia if we had started it and to start rewarming the patient slowly. So some of the reasons to stop therapeutic hypothermia and to rewarm are hypotension despite inotropic support, persistent pulmonary hypertension with hypoxia despite ventilatory support, significant coagulopathy, and subcutaneous fat necrosis. As I said before, HIE is a complex neurological injury that requires multidisciplinary support. And I know that I did not cover all the details related to this condition, but I hope that you feel that you got some of the highlights. While there is much to learn and more adjunct therapies that are being tested to be provided alongside therapeutic hypothermia, my hope is that you learned a little bit about the mechanism of injury and some of the key points in the safe transport of these patients. Most importantly, make sure that you check with your program and are familiar with what tools you have available for deploying or maintaining therapeutic hypothermia for these newborn patients. And I hope this brief review has been insightful. Thank you so much for your time.